Very good morning to all of you. Welcome once again to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. We have Dr. Rajeev Kumar, and the moderator would be Dr. Somendra Bansal. Today, very renowned
Sir, voice again, credits.
Voice not. Can you hear me now?
Yes, sir. Yes, sir.
Your voice was breaking earlier. It's better now.
Okay. So I welcome Dr. Madhusudan.
Again, sir, voice is gone, sir. It's cracking again.
नहीं शिवम का कनेक्शन ही कुछ गड़बड़ है.
I will get back. Go ahead, Rajeev.
Sir, good morning, everyone.
Yeah, just don't show the presenter's view. This is make it a full screen.
Recording in progress.
ठीक है हो रहा है हो रहा है बस ऐसे कर रहा हूं.
Should I start, sir? Yes. Good morning, everyone. Today I am presenting a seminar on neurotechnology for treatment of BPH. These are the few techniques which we will be discussing in this presentation. First of all, the intraprostatic stent. Stents are introduced by Fabian, and they are placed in prostatic urethra. They require functional detrusor so that the bladder still has the ability to empty itself. These are stents are alternative to an indwelling catheter in unfit patients. There are two types of stent: temporary and permanent. Permanent stents are biocompatible and they allow epithelialization so that eventually they become embedded in urethra. On the other hand, the temporary stents neither become covered by urethral epithelium and nor become incorporated in urethral wall. These are made up of either non-absorbable or biodegradable material. Non-absorbable stents need to be removed every 6 to 36 months. These are different type of temporary stents: spiral, polyurethane, and the biodegradable stent like polyglycolic acid. Permanent stents are Urolume, Mammotham, ASI stent, and Ultraflex stents. Indication for stents are the temporary stents are used as an alternative to catheterized for elderly and frail patient unfit for surgery, and they are also used as a temporary retention in the case of temporary retention that can occur secondary to treatment such as TUMT or TUNA. Permanent stents are used in recurrent urethral stricture, detrusor sphincter dyssynergia, in advanced prostatic cancer with bladder outlet obstruction, on post-chemotherapy, post-brachytherapy, bladder outlet obstruction, and anatomical strictures. Contraindication for prostatic stents are detrusor failure and untreated urethral stricture, previous TURP patients. Coexisting bladder cancer is also in contraindication. And next is spiral stents. Spiral stents are Eurospiral, Prostacan. These are made of stainless steel And neither of these stents should remain in prostatic urethra for more than 12 months. These are can be inserted with the help of pen endoscope or under ultrasound guidance. Spiral stents are Mamocanth is one type of spiral stent. It is made up of nitinol, is a nickel titanium alloy. It is a malleable and heat expandable stent at the temperature of 45 degree to 50 degree. It is soft malleable when cooled and returning its original shape when heated to the preceding temperatures. It permits the passage of flexible cystoscope and may be left in place for up to 36 months. And Prostacoil is another type of spiral stent. Polyurethane stents are intraurethral catheter and made up of polyurethane material known as Buroflex, and these can be placed for up to a period of 6 months, and they have a double device at its tip end, and it has a nylon string at its distal end and a flared split and proximal end which sits in the bladder. These should not be inserted in the presence of bladder stone or anything else likely to block have a ball valve effect on device. Polyurethane stents are one other example is testless stent. Permanent stents are uroloom is commonly used, and it is the endourethral prosthesis which is woven tubular mesh that maintains its position in the urethra by outward external pressure. It is inserted with the help of deployment tool under the 0-degree pen endoscope. It gradually epithelializes and ideally in smooth manner, covering the individual wires of the mesh. Original stent used to tended to shorten while it expand outwards. Mammothumb is another type of permanent stent. It is also made up of nickel titanium alloy, and its length is 1.5 to 8 centimeter. It is inserted under 0-degree telescope. The complication of stents are encrustation, stent migration, incontinence, recurrent UTI, and these are not positioned inside the external urethral sphincter because it may cause stress urinary incontinence. And bad adverse event immediately following stent placement is perineal pain and irritative voiding LUTs. Systemic review of uroloom says that the failure rate of stents is at 16% at 1 year and 27% at 5 years. And the stent misplacement and the recurrent obstructive or irritative LUTs are the other side complication of the stents. Next minimal invasive technique is a transurethral needle ablation. It is transurethral needle ablation uses a low level frequency radio frequency energy that is delivered by needle into the prostate. There is radio frequency waves causes coagulative necrosis in lesion in the hyperplastic tissue and consists of a special catheter attached to a generator. At the end of the catheter there are 2 adjustable needles that are withdrawn into 2 adjustable shield made up of Teflon. The generator generates a monopolar radio frequency signal of 490 kilohertz. The TUNA is excellent, has excellent penetration and uniform tissue distribution. Radio frequency power that is delivered is to 15 watt for 5 minutes per lesion, and temperature at the tip of the needle is 80 degree to 100 degree, whereas the urethral temperature is kept less than 46 degree. The thermal lesion may extend up to 5 to 6 millimeter beyond position of needle deployment, with the lesion measuring up to 20 to 10 millimeter. The number of lesion depends on the size of the prostate. For example, 1 pair of lesion should be used to treat 20 gram of prostatic tissue. TUNA system can create 1 centimeter necrotic lesion without difficulty in the prostate and no damage to the surrounding structure. And the configuration of needles assures that prostatic urethra is spared. Topical anesthesia can be used with patient experiencing only moderate discomfort, and post-procedural irritative LUTs are kept to the minimum. Difference in method of other type in the newer generation of radio frequency is in place of radio frequency they can use microwave application, because microwave treats a broad area and can penetrate tissue more deeply into the area than the radio frequency. The central temperature of microwave is kept lower. That's why the treatment for microwave takes longer than radio frequency to produce coagulative necrosis. The most up-to-date version of TUNA catheter is called ProView system, and part of this device is reusable, unlike previous models. Indication for TUNA is the ideal patient are the men who are less than 70 years with a prostatic volume of less than 60 ml and the pre-treatment PDAT at peak flow rate of less than 60 centimeter of water with the residual volume of less than 100 ml. Few adverse event compared with TURP includes mild hematuria, urinary tract infection, stricture, incontinence, and ejaculatory disorder. Contraindication of TUNA is active UTI or neurogenic decompensated bladder, urethral stricture, bleeding disorder, and too small or too short, too large prostate transverse diameter, and the presence of implants of which action can be hampered by radiofrequency like cardiac pacemaker and penile implants. Adverse effect with TUNA is the most common is post-treatment urinary retention followed by irritative voiding symptoms, and these are seen in initial 4 to 6 weeks. Advantage of TUNA is its short stay and outpatient procedure, but the disadvantage is that there is no tissue is left available for pathology. TUNA has a significant high retreatment rate of 19.1%. Next is the transurethral microwave therapy. Microwave radiation runs through an intra-urethral antenna in order to deliver heat into the prostate. The tissue is destroyed by being heated at temperature above cytotoxic threshold and causes coagulative necrosis. Heat is mainly produced by electric dipoles, that is water molecules oscillating in the microwave field, and electric charge carriers moves back and forth in the microwave field. It causes apoptosis and denervation of alpha blocker, thereby decreasing the smooth muscle tone of the prostatic urethra. TUMT involved insertion of a special designed double urethral catheter in the bladder, allowing a microwave antenna to be properly positioned within prostatic fossa. Disposable treatment catheter contain microwave antenna, closed water coiling circuit, and retention balloon. It is performed on an outpatient basis and usually takes 30 to 60 minutes. There are two most commonly used TUMT devices are Prostatron and Targis. The retreatment rate at low energy is around 85%, whereas in high energy TUMT, the retreatment rate is around 25%. And catheterization time, incidence, and dysuria, urgency, and urinary retention were significantly less when with the TURP as compared to TUMT, whereas incidence of hospitalization, hematuria, clot retention, transfusion, TUR syndrome are significantly less with TUMT. The TUMT is associated with a longer catheterization as compared to TURP, and sexual dysfunction retreatment rate of meatal stenosis or urethral or bladder neck contracture were higher after TURP than TUMT. EUA guidelines recommends TUMT for the patient with large prostate and high grade of bladder outlet obstruction. There is one other side effect of TUMT is there here also. There is no tissue available for pathology, and it is contraindicated in case of implants or urethral stricture disease, or a patient with peripheral artery disease with intermittent claudication, and a patient who have received radiation therapy in the pelvic area. Intraprostatic ethanol injection is also a minimal invasive technique in which the absolute dehydrated ethanol injection is injected into the prostatic parenchyma for the treatment of LUTS secondary to BPH. Precise mechanism of action in both human and animal remains unclear. It is postulated to cause inflammation, coagulative necrosis, and protein denaturation and cell death by membrane lysis, and finally atrophy and ablation of prostatic tissue. Intraprostatic cavity formation appeared in canine model after 7 days. It can be injected transurethral, transperineally, or transrectally under USG guidance. Specific devices for transurethral delivery of ethanol are also available. There is no consensus on the number of injection site or injection volume, and it can be done under local, regional, or general anesthesia. Procedure is usually completed within 30 minutes, and most patients need an indwelling catheter after procedure. After an initial strong reduction in the prostatic volume, it has been seen that prostate size has increased again by 1 to 2 years post-operatively, although the loads and Qmax remain significantly improved. The retreatment rate is of 41%, and the side effects are perineal abdominal discomfort, bladder storage symptom, and hematuria and infection. Intraprostatic botulinum toxin is also used as an injection. Botulinum toxin is an exotoxin of bacterium Clostridium botulinum. Most common, it is known as the most common neurotoxin known in human, and it causes botulism. There are 7 types of botulinum toxin, out of which subtype A and B have been manufactured for the use in humans, and only Bonta A is used for intraprostatic injection for treatment of fluids and bladder outlet obstruction. Neurotoxin, it causes neurotoxin-induced denervation trophy and induction of apoptosis and inhibition of proliferation and downregulation of alpha-1 adrenal receptor in the prostate that may contribute to smooth muscle cell relaxation. Under ultrasound guidance, Bontai injection injected into prostatic parenchyma transperineally, transurethrially, and transrectally, and there are different units of prostate botulinum toxin is used as in the according to the size of prostate volume. The most patient treated without anesthesia or local anesthesia or short sedation. Prostatic volume seem to be increased again after 6 to 12 months of injection, despite stable improvement in symptoms Qmax and PVR. The retreatment rate with botulinum toxin were higher as 29%, and main complications of botulinum toxin injection are dysuria, hematuria, and prostatitis. There are no impact on sexual function is seen with botulinum toxin injection. And TUVP, that is the transurethral vaporization of prostate, is has two electrosurgical effects are combined in TUVP, that is vaporization and desiccation. Vaporization steams tissue away using high heat, that is more than 300 degrees centigrade, and coagulation uses lower heat to dry out the tissue. Vaporization occurs at the leading edge and desiccation occurs at the trailing edge of the electrode. For TUVP, the cutting current power should be kept to a maximum of 75% higher than the standard TURP initially, but it has been estimated that a minimal power of delivery of 150 watt is required for TUVP. There are two types of electrode used in TUVP, that are roller ball used for a small area to vaporize, and when we need to a larger area to vaporize, we use grooved roller bars. And newer second generation TUVP techniques uses vaporization along with resecting electrodes, that are known transurethral vaporization, resection of prostate, thick loop TURP, vapor cut electrode vaporization resection. Efficacy appears similar to that of TURP, but studies are short-term evaluation, and glands supported on are relatively small. Short-term complication profile appears to be better than the TURP, but further studies are required. In general, although the catheterization time is shorter than the TURP, the operating time is longer. The retrograde ejaculation were lower in the TUVP group. Prostatic artery embolization is another minimal invasive technique explained by Lang for the treatment of intractable prostatogenic hemorrhage, and it uses a multidisciplinary team of urologists and intervention radiologists, and indicated in case of symptomatic BPS that are refractory to medical treatment. Potential benefit of prostatic artery embolization over surgery is the reduced morbidity and avoidance of general anesthesia. It is usually performed under local anesthesia and sedation. Aim of prostatic artery embolization is to reduce blood supply to the prostate and causing some of it to undergo necrosis with subsequent shrinkage. Using percutaneous transfemoral approach, superselective catheterization of small prostatic artery is done using microcatheters. Embolization involves introduction of microparticle to block these small prostatic artery. The agents used are polyvinyl alcohol or gelatin sponge. Current evidence on the safety and efficacy of prostatic artery embolization for BPH is inadequate in quality and quantity. Compared complication of prostatic artery embolization, theoretically it causes adverse event on inadvertent embolization and subsequent infarction of adjacent organs such as bladder and possibly rectum. It can damage the cavernosal artery that can cause erectile dysfunction or damage to the external urethral sphincter leading to incontinence. Arterial pseudoaneurysm, urinary fistula, prostatic abscess, dysuria or other side complication of prostatic artery embolization. Next is prostatic urethral lift. Prostatic urethral lift, also known as urolift, procedure involves delivery of implant that retract obstructing prostate lobes using urolift device. Mechanically, it opens the prostatic urethra with urolift implant that are placed transurethrially under cystoscopy visualization, thereby separating the encroaching prostatic lobes. It does not appear to cause retrograde ejaculation, that's why preserving erectile and ejaculatory function and improves symptom and voiding flow. Aim of urolift procedure is to create an anterolateral channel from the bladder neck to the verumentinum Maybe it can be performed under local spinal or general anesthesia with or without additional sedation. It has ability to perform procedure under local anesthesia. That's why it is advantageous for patients with significant multiple comorbidities. Patient selection is ideal prostatic anatomy for successful urolift procedure is where lateral lobe enlargement is responsible for bladder outlet obstruction, and bladder neck should be normal with minimal median lobe enlargement. Size of prostate in selected patient should not be more than 100 cc. May be ideal for younger sexually active men who request management of bothersome LUTS, or the patient who are averse to the cavitating surgeries. And this is a urolift device comprising customizable nylon suture and suture delivery device, which is introduced under cystoscopic guidance. Efficacy in improving symptom score and quality. This is technique is the delivering of urolift device. The device is introduced under cystoscopic guidance. Lateral lobe of prostate are compressed by device and needle is deployed. Additional suture may be delivered if needed to maintain a patent urethral lumen. Efficacy in improving symptom score and quality of life is, in men with LUTS is proven, and not only are the clinical outcome following PU are immediate, but they have also demonstrated durability for up to 2 years. Since procedure does not affect integrity of bladder neck, integrate ejaculation is maintained, and in the absence of thermal tissue damage, risk of erectile dysfunction is minimized, and adverse effects like dysuria, hematuria, and pelvic pain are seen in 36, 26, and 21% respectively. Next is the aquablation. Aquablation is the ultrasound guided surgical technique that uses a heat-free high velocity water jet. There are 3 main components of aquablation, that is robotic handpiece, surgeon console, and the CPU. It is done under general or spinal anesthesia. The maximum angle of resection with aquablation is 225 degree, and the maximum depth, cut depth is 25 mm. Aquablation works in a windshield wiper motion with high velocity saline, follows the outline field and dissect the obstructing prostatic tissue while sparing the bladder neck and verum montanum. Average resection time is around 5 minutes, and hemostasis may be achieved through focal bladder neck cautery. Efficacy and safety of aquablation is proven by the Water and Water 2 trial. It is approved by US FDA in 2017, and it's said that it is non-inferior in efficacy and superior in safety as compared to TURP. The rate of anejaculation was lower after aquablation, and there is no statistical significant difference in IPSS reduction or quality of life reduction, and the Qmax increase across group and across time comparing aquablation with TURP. Aquablation is an effective surgical technique for large prostate for more than 80 cc. Adverse effect of aquablation is there is a risk of blood loss and possible transfusion. It is not an approved treatment for BPH for men on anticoagulation, and it lacks a direct method to achieve post-resection hemostasis. This is the device used in aquablation. Next is the resume, better known as it is a water vapor thermal therapy. It is thermal ablative technique that achieves heat transfer via convection, and it is an office-based setting and is typically done using oral sedation. Tissue necrosis at a lower temperature in a shorter amount of time is a working advantage of resume. The key component of this system include a radio frequency generator, a single-use transurethral delivery device with an integrated 30-degree cystoscope lens for direct visualization, and a 18 gauge retractable polyether ether ketone needle and a saline flush. It is done in local or block or sedation. The surgeon guides the delivery device into prostatic urethra under direct visualization. The radio frequency generator converts sterile water into steam that is then delivered and injected into the prostatic adenoma tissue by delivering device and peak needle. When the steam travels through the prostatic adenoma, it immediately phase shift from vapor back to liquid, releasing and transforming the 208 calorie of thermal energy to the target tissue. This release of stored thermal energy causes irreversible cell membrane damage and cell death. Efficacy and safety is investigated in Resume 2 trial, and it explains that significant decrease in IPSS and IPSS quality of life and increase in Qmax. as compared to TURP, and medical retreatment rate is 11.1%. Surgical retreatment rate was 4.4% with no erectile dysfunction and retrograde ejaculation in treatment arm. Minor temporary complications like dysuria, hematuria, frequency, urgency are seen with this technique. This is a resume delivery device and vapor needle. Next is ITIND. That this is a temporarily implanted nitinol device that is deployed in the prostatic urethra and bladder neck. The device has a 3 elongated nitinol struts connected at the distal end and an anti-migration anchoring leaflet and a polyester retrievable sutures. Using a cystoscope, the device is deployed and retracted to the anchoring. So with the help of anchoring leaflet in the ureter under the bladder neck at 6 o'clock position, and 3 struts are placed in 12, 5, and 7 o'clock position with the within the prostatic urethra. Once inserted, the bladder is drained and patient is discharged with simple analgesic. The total procedure time is less than 10 minutes, and the most cases are done in office-based setting under local anesthesia. It expands and reshapes the bladder neck and prostatic urethra, creating an open channel. After a week, the device is removed by using the retrievable suture, and catheterization is not necessary after placement of this device. Patients are discharged on the same day. This is a second generation ITND device with 3 struts on 1 anchoring leaflet. Efficacy and safety is approved, is investigated, and it is given approval by US FDA in 2020. And it has been seen that there is significant reduction in IPSS at 3 months as well as at 12 months, and similar improvement in the IPSS quality of life at 3 months and 12 months. And QMAX is also significantly improved.
Significant नहीं लिखा है, improvement लिखा है. All your parameters are improvement. It's not significant improvement. Okay, go ahead.
There is no reported de novo retrograde ejaculation or erectile dysfunction. Retreatment rate within 1 year was 4.7%. There are minor self-limiting complications seen like urgency, hematuria, and dysuria. This is the RCT trial, RCT comparison of 4 technique aquablation, resume, urelift, and ITND. It shows that all of 4 devices associated with the low rate of anejaculation and erectile dysfunction. And aquablation is known to is good for large size of prostate, and except urolift, all the other 3 devices can be used. Techniques can be used in case of median lobe enlargement also. Thank you.
Okay. Unshare.
Thank you, Rajeev. So can we just make it full screen? Yes. Perfect. So I welcome once again Dr. Madhusudan Agarwal, who has been kind enough to join us today as an expert faculty. As you all know, Dr. Madhusudan is not just a SMS alumni. He has been the past president of Urological Society of India, presently the president of SARC Association. He has been doing workshops around the whole world with PCNL, mini PCNL, and also enucleation, prostate enucleation, bipolar enucleation. So welcome, sir. And before I just give my comments, I would request you to please come and give your comments on the newer technologies which are coming up in the management of BPH. Dr. Madhusudan, please.
Well, Shivam, thanks very much for this invitation. It's always a pleasure to join, come back to the alma mater, SMS, which is so close to my heart. I mean, it always is. And it's very good to see how you have revived, rejuvenated the academics in SMS. I mean, I'm really full of admiration the way the academics in SMS urology has picked up under your guidance. And these classes, I think, is a masterpiece. So it's very educative, very good academic content, and I'm really happy to be a part of this. So this particular topic of newer advances in BPH management is actually a very, I would say, there was one session on hot topics in SIU meeting in Montreal this year. One of the hottest topics, I would say. And there is so much happening around the world on this subject. So can we go back to the first slide on which Rajeev, you had put up all the options, all the newer technologies.
Yes, Doctor.
अपनी पहली दूसरी slide दिखाओ जिसमें सारे options आपने डाले हुए.
Yeah, he would share his presentation and then he has to share.
So what I would suggest, first of all, for Rajeev, you and for anybody who's presenting this. Now keep showing that presentation.
Okay, leave it. I think.
So it is always good to, first of all, categorize the newer alternatives into different basic categories. The stents, the ablative techniques, the the thermal ones, the mechanical ones. There are very good classifications available where you can describe the different, instead of putting them all, bunching them up together like this. It would have been better if you had, or at least in future we can do that, put them all in different subcategories and then discuss them one by one. And the other thing is that upfront we should talk about the indications and benefits of alternative treatments over the gold standard therapy, that is the TURP. In addition, I think it's very important to talk about the role of the newer gold standard, and that is the bipolar treatment, because bipolar can be considered a newer therapy, but it can also be considered the new gold standard, a replacement to the conventional monopolar. So I think that should find a place in this discussion. But all in all, I think you made a very nice presentation, covered all the newer advances very well. Although there are so many that in a limited time, I suppose you cannot do justice to everything. And in the end, the last slide that you showed, where you highlighted the last 4 ones, these are the ones which are actually the most popular today. And most work is now being done in these 3-4 new technologies. So I think it is a good educative seminar, and it is of theory importance. I think you would get questions in the exam, and at the same time, it is also of a lot of practical importance.
Thank you, Dr. Madhu. And what is, I think, these technologies have been coming up for last many decades, right? If I remember, the alcohol injection probably came half a century ago from our country only, and then it has again come back. Ajmer, doctor surgeon probably started giving intra-alcohol injection. Dr. Talwar, general surgeon, and then now it has come back again. But probably none of them has stood the test of time. Probably. Many we started with kind of hypothermia, then TUMT, then transurethral needle ablation, which came in a big way, but again went away. And what if I am permitted to say that the fashion today is of the Eurolift and the aquablation and prostate artery embolization. Many of the invasive radiologists now are doing many of these cases with embolization. But again, this is maybe my personal feeling that most of them have some kind of industry-driven kind of thing, and probably they still do not come anywhere near the gold standard TURP, or as you said, the bipolar TURP, or even the enucleation of the prostate hole. And only in patients, even if we say that these are the cases where the technologies where we have to see only those patients who are not fit for surgery, like general anesthesia or regional anesthesia, even then, I don't think many of these procedures are not good for actual indications when the patient comes in retention or there's a high residual urine. These are not good indications. So, so Dr. Madhu, what do you do? What are your comments on this particular take here?
Actually, I agree 100% with you on this. All these alternative or minimally invasive therapies follow the same path. The less invasive they are, the less effective they are. And one cannot rule out the role of the industry drive and many times hidden conflict of interest in even the publications. We have all seen that, and there has been a steady stream of these alternative therapies which have come and gone. And I'm reminded of that the story which was told in one of the UCCons many years ago by one of the past presidents of the senior professor who got tired of his long-standing marriage and took fancy to his new attractive secretary. So he went around with her for a while, was very happy, but she soon realized that she was very temperamental, unpredictable, and too expensive to maintain, and got tired and went back to his old faithful wife of many years. Okay. So I think that is the story of most of these minimally invasive therapies which have come and gone one by one. None of them, as you said, has stood the test of time.
Right.
But let's see. I mean, people have been trying constantly, and we have all seen over the past few decades. Yeah. There are some promising things. Some things have come and stayed. Like they are not exactly minimally invasive, but like bipolar has come and stayed. Yeah. Lasers have come and stayed. I mean, HOLAP has a role which cannot be denied. Right. And among the newer technologies, what I would say is that one approach which appears to have some promise for future is aquablation, because it actually ablates the adenoma, because it is based on ultrasound sound principles, and because it is computer driven. And it is one thing which we used to imagine as postgraduates, that one day a machine will come that you set it up and put it on and leave it alone, and it will enucleate, drill out the prostate. So something similar to that is happening now, that you set it up, switch it on, and it kind of takes away the enlarged adenoma after you put all the settings in place. So maybe aquablation has a future once it becomes affordable and once everything, all the wrinkles are straightened out. But all others have already started to show their limitations. And I have talked to many of my friends abroad, in UK, in Europe, in Far East like Singapore, who have actually been using things like UroLift. And contrary to the published results and the great enthusiasm shown initially, they are very, very of things like UroLift, and the long-term results don't seem to already don't seem to stand the initial promise. So many of my friends who are actually doing it in UK is the place where they talk maximally in NHS about the benefits of UroLift, because they don't have they have long waiting lists. So they are very happy doing something which is a daycare procedure, send the patient home the same day. So things are different for us. For us, I think something which is lasting, which will give the patient cure, is of greater value.
Yes, rightly said. Aquablation, I think, yes. Recently, we had a machine, RB machine with hydrojet. So we did a partial nephrectomy, enucleation of the tumor with a hydrojet.
Okay.
I think it's very kindly very similar to aquablation. Only thing is that there is a robotics also involved in it, and you don't have to do it, and the robot does the whole thing after making that programming. So, but the main disadvantage again is that you have to put the patient under regional or general anesthesia for aquablation. And it's not the minimally invasive approach which can be done under office-based local anesthesia, etc. So that is probably one of the disadvantages of aquablation. What I feel that even smaller things, like we have a flexible cystoscope. Why can't we do with a flexible cystoscope just a laser incision of the bladder, neck, or even TUIP, which can be done in the office only? And we can make 2 incisions, 5 and 7, or maybe even one more at 12 o'clock, and see what are the results. Which so simple things like this. One of our residents had a kind of a study on ketoconazole in patients with retention urine. So when we gave ketoconazole to these patients along with alpha blocker, they had a better results, and they actually got relieved of retention, and they started voiding. Similarly, there are cases with LHRH injections, which can be given along with alpha blockers. So some of these, which are very kind of simple and cheap and easily available, could be actually very kind of they can be used in many of these patients where we cannot do these TURP or bipolar or HOLEP. So what I remember, one of the debates that we had in our North Zone annual meeting, which was on neotechnologies in BPH, whether this is a hype or actually useful. Dr. Nachiket was the debater. So I would invite Dr. Nachiket to give a few of his comments on this. Dr. Nachiket, please.
Good idea.
Sir, good morning, sir. Pleasure to have you in the class today. So I think that it was, as you said, it's a very important topic for the residents, because by and large, every second year, they have this fixed question upon minimally invasive treatments for prostate. And I think that both you and sir have been absolutely correct. Inside, I think for the residents, I want to say that interpretation of results is very important. This is because what happens is that when somebody presents a paper regarding a new therapy, then you also have to look into what is hidden. For example, even Rajeev, when he was presenting about, the improvement in parameters. So if you look carefully, the improvement of parameters. So the Qmax inside one of his studies on RESM said it improved from 8 to 12. But is it significant? In the same way, IPSS, he said that the improvement in IPSS was, say, 4 points or 5 points. In one study, he said that it was improvement in 6 points. Now, we all know that the IPSS, it ranges from 35 to 7. Now, say if a patient has an IPSS of 32 and it comes to 25, it's not going to be a significant improvement for the patient. I mean, he's still going to be having moderate bothersome symptoms. And so what the patient is not concerned about the IPSS, or, he's concerned about how he's perceiving his bothersome symptoms after the procedure. So it's very important to look deeply into how you interpret the results of all these studies. So that is why when Rajeev was presenting, then I prompted him that, look, it's not written that it was, significant, statistically significant all the time. For example, if your even PVR is improving, or if your, say, other parameters are improving, but you have to have a good head-on trial with as the gold standard. Every time when you read a paper, then they'll be coming as compared to our gold standard, the TURP, the TURP, and the TURP. And so I still think that, as Sir as was talking about bipolar will give a good challenge to any of these new modalities. And as far as the debate that we had inside North Zone, there is data on the NHS website. NHS conducted a study, an 8-year-old study, in which 4 years they used different modalities like Eurolift and RESM, and new patients were included, and it's just concluded in 2019. And they spent 1.3 million pounds. And ultimately, at the end of the study, the result was, and it is there on their website, that still bipolar enucleation or bipolar TUR is better than any of these modalities. So it is there for you to study on the website of NHS. And I think that I quoted that study inside that debate also. So they are good investigational modalities, but still our gold standard would be for a country like us, TURP, especially bipolar, our results are excellent, sir. Thank you, sir. And Ji, sir, your comments, sir.
Yes, Dr. Madhu, your comments. Yes, please.
Yeah, I'd like to add one more thing. As a temporary measure, I find stents very useful. We've been using stents for many years now. I conducted a study with TRANSURETHRAL when it was introduced by Boston Scientific almost 30 years ago. We were part of a multinational study on TRANSURETHRAL. TRANSURETHRAL is a temporary urethral stent. And I've been interacting with Dr. Yachia, one of the first people to start doing prostatic stents. We have been using Mammotherm regularly, and before that, we used Urolume. We had bad experience with Urolume because Urolume gets incorporated and encrusted, and then removing Urolume is a nightmare. But Mammotherm was a very good stent to use. And the benefit of temporary stent is in patients who are unfit for TUR temporarily or for a prolonged period. For example, somebody who has a MI and goes into retention. Now, the cardiologist will not allow you to operate until 3 months or 4 months. Somebody who's got a massive MI and retention, and leaving that patient on a catheter for 4 months is tiresome. I mean, who would want a catheter for months on end? So in these patients, stents are very useful as a temporary measure. And at the end of 4 months or 6 months, you can remove the stent and do the TUR. And some patients who are completely unfit for surgery, these stents can be left longer. And we have had patients who lived their last few years on stent alone. So we were using Mammotherm regularly until they stopped becoming available in India. We milta hi nahi hai. So now there is a new stent called Allium stent, which is now available. And we are now using Allium stent with good results. Multiple cases we've done. And these patients are able to pass urine. Somebody with an ejection fraction of 21%, completely fit, unfit cardiologically, or somebody who's got an MI, or somebody who's got such a bad chest that he cannot have anything. And retention of urine, these alternative therapies, I'm not sure how effective they will be in such scenarios, but stent works because you put it in, it leaves the urethra open, patient is able to pass urine the next morning and goes home. So I think stents have a place.
Yeah, thank you, Dr. Madhu. Yes, stents can be used in many of these acute settings when we are not able to do any kind of definitive approach in these patients. So, but then again, most of them are probably for temporary use.
Yes.
And we have to do a definitive surgery later. And yes, besides stents, the simpler things which may not be as good as stents, but they could be like putting the patient on CIC or even putting a suprapubic catheter for temporarily. So that could be maybe one of those options where we can help these patients. So thank you, Dr. Madhu, for joining us in our teaching class today. And I thank all the residents, all faculty members, and all those who might have joined us today on Zoom and YouTube. Thank you once again. I thank Dr. Somendra for moderating the session and Dr. Rajeev for presenting a beautiful topic. Thank you very much.
Thank you. Thanks a lot.
Thank you.
For having me.
Thank you.
Thank you. Bye.